Hi, I'm Joe Graydon.
I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy, where we bring you the stories behind the health headlines.
This podcast is brought to you by Redix Industries, makers of Utterly Smooth Body Cream. 800-345-7339, on the web at uttercream.com. New research on cholesterol-lowering drugs has cardiologists confounded. What should patients make of conflicting conclusions? This is the People's Pharmacy with Terry and Joe Graydon.
Cardiologists from around the country met in Chicago last weekend. One of the studies presented there shows that patients have been right about statin side effects. What should people do if their muscles hurt when they take a statin?
A tick bite could result in a surprising allergic reaction to barbecue or burgers. Symptoms may not show up until hours after someone has eaten meat. How would you know if you or someone you love has developed an alpha-gal allergy?
Coming up on the People's Pharmacy, your calls and questions about the health news that matters to you.
First, the news.
In the People's Pharmacy health headlines, when the cardiologists gathered in Chicago at their annual meeting this week, they learned about a big new study called HOPE-3. What the scientists and their pharmaceutical sponsor, AstraZeneca, were hoping for was evidence that a single polypill to treat cholesterol and blood pressure would save lives from heart disease. The trial was complicated, though, and the results were published in 3 separate reports in the New England Journal of Medicine. In the first analysis, scientists compared the rates of heart attack, stroke, and cardiovascular death in 12,000 people randomly assigned to take either Crestor or a placebo. None of these folks had heart disease at the beginning of the study, which lasted 5 to 6 years. Crestor did its job lowering cholesterol. Those taking this statin reduced their bad LDL cholesterol by about 26% compared to those on placebo. They were also about 1/4 less likely to have a heart attack, a stroke, or die. In absolute terms, a little more than 1 person in 100 got that benefit. The researchers note that a few more people on Crestor than on placebo needed cataract surgery, and those on Crestor were more likely to report muscle pain. There was no significant difference in mortality between volunteers taking Crestor and those on placebo.
A different study reported that cardiology meetings had disappointing news. Cardiologists have been taught that lowering LDL cholesterol and raising HDL cholesterol is the path to preventing heart attacks, strokes, and premature death. Eli Lilly sponsored a study involving over 12,000 patients who are at high risk for cardiovascular complications. Roughly half were randomized to take an experimental drug called evacetrapib, while the others were given a placebo. All the patients were also on standard medical therapy, which means that many were taking statins as well. The new medicine was extremely effective at lowering bad LDL cholesterol, which went down by 37% on average. It was even better at raising good HDL cholesterol, which went up 130%. Virtually no medicines to date have been able to produce such spectacular changes in blood lipids. That said, the study was a bust. The trial was ended prematurely because there was no difference in heart attacks, strokes, or cardiovascular mortality between the two groups. These results have left many cardiologists wondering why a drug that changed cholesterol so effectively had no impact on survival.
Many patients taking statin-type cholesterol-lowering drugs have complained about side effects such as muscle pain and weakness. Most clinical trials have found that these adverse reactions are rare. As a result of these reports, some cardiologists doubt that patient complaints are real. But a new study published in the Journal of the American Medical Association suggests that a significant proportion of people do indeed suffer from statin intolerance. Researchers recruited roughly 500 patients who had previously reported muscle problems while taking a statin. They were randomly assigned to receive either atorvastatin or a lookalike placebo. The investigators discovered that 42% of these subjects experienced muscle symptoms while taking atorvastatin but not while taking placebo. Dr. Steve Nissen of the Cleveland Clinic was the lead author. He estimates that as many as 10% of patients on statins may experience muscle problems. In a second stage of the study, the researchers gave statin-intolerant subjects either ezetimibe or evolocumab to lower their cholesterol. 29% of those taking ezetimibe and 20% of those on evolocumab complained of muscle cramps, spasms, weakness, or pain. That's fewer people than suffer on statins, but still significant.
A small study from England found that vitamin D supplements improved cardiac function in people with heart failure. 163 people with heart failure were given either 4,000 international units of vitamin D or a placebo for 1 year. The amount of blood that the heart was able to pump increased from 26% to 34% only in the people on the nutritional supplement. If this preliminary research holds up, it could be an important therapeutic advance in the treatment of a common and serious heart condition. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Terry Graydon. I'm a medical anthropologist.
And I'm Joe Graydon. I'm a pharmacologist. It's been a big week in cardiology because several important studies were released to coincide with the annual meeting of the American College of Cardiology. Today, we're going to be talking about the latest research on statin-type cholesterol-lowering drugs with one of the principal authors, Dr. Steve Nissen, chairman of the Department of Cardiovascular Medicine at the Cleveland Clinic, will join us later in the show.
We'll also be talking about a very unusual type of food allergy. Can people really become allergic to bacon, burgers, and barbecue because of a tick bite?
But first, we're talking with Dr. Robert Dubroff. He is Associate Professor of Medicine in the Division of Cardiology at the University of New Mexico in Albuquerque, New Mexico. He's board certified in internal medicine and cardiology. His specialty is lipidology. Welcome to the People's Pharmacy, Dr. Dubroff.
Thank you.
Dr. Dubroff, it's our understanding that besides being a cardiologist, you are a lipidologist. What in the world does that mean?
Well, a lipidologist is a physician who specializes in cholesterol or lipid disorders. It's become a specialty unto itself because it's gotten fairly complicated.
Indeed it has, especially lately.
Now, Dr. Dubroff, you have written 2 articles that are quite fascinating. One in the American Journal of Medicine titled, "Should Statin Therapy Be Guided by Cardiovascular Risk Models?"
The other one's entitled, Does Improve It Prove It?
And so we kind of would like you to summarize what your research has led you to think regarding cholesterol and lipids and cholesterol-lowering drugs from these 2 articles. And then we'd like to talk to you a little bit about what just happened last weekend at the American College of Cardiology meetings in Chicago. But first, your observations about statins in general and cholesterol-lowering drugs and cholesterol and heart disease.
Well, let me start first with my article on the Improve It study. The Improve It study was a randomized trial where they compared a statin drug, simvastatin, to the combination of simvastatin ezetimibe to see if additional lowering of LDL cholesterol would achieve additional benefit. And the reason that's such an important study is it really tests something called the cholesterol theory or hypothesis. This theory essentially says that high levels of cholesterol cause coronary artery disease, and the more you lower your cholesterol, the more benefit you're likely to see. So the study itself was well conducted, and the conclusion of the study was that if you do lower your LDL cholesterol further with the simvastatin ezetimibe combination, you do in fact see a modest additional benefit in terms of a reduction in cardiovascular events. But what I tried to do in my article is to review not just this study, but several other studies regarding this whole concept of cholesterol, statins, and cardiovascular disease. And essentially what I found is that not all the data fits the theory. Specifically, there are quite a few studies, randomized controlled trials, that show even when you do lower cholesterol, either with diet or drugs, the results are very inconsistent. There's no question some of the studies show a benefit in terms of reducing heart disease, but there are dozens of studies which have failed to show an improvement in heart disease or mortality. So these are rather confusing and contradictory results.
Well, let's just pause there for a moment because, the whole point of the exercise in theory would be to reduce mortality, that is to help people live longer and healthier. And a few months ago, I was with a bunch of physicians and I asked them, so how much time do statins buy you in terms of longer life? One physician said, well, I think it's probably 2 to 3 years. Another one said probably 4 or 5 years. And yet when you really look very closely at the data, you discover, well, maybe a month, even after 5 or 6 years of treatment. So this mortality issue is a little bit confusing to doctors as well as patients.
Absolutely. And in fact, there was a study which looked at this question published in the British Medical Journal not too long ago. And if I'm not mistaken, their conclusion was that at best you get about a week of prolonged life with statin usage. So the mortality benefit, if anything, is very modest, or it may even be non-existent with statin therapy or cholesterol lowering. And I think one of the problems with much of the clinical research in this area is the focus has shifted from looking at mortality to looking at what are called combined endpoints, where they combine several different things and consider it a positive outcome.
Why do they do that combined thing?
Well, there's a number of reasons. I mean, there are good and bad points of using what are called combined or composite endpoints. The simple answer is it's a little bit easier to show a positive effect when you use a combined or composite endpoint. The downside is you often are equating different outcomes. For example, in some studies, it's considered a positive outcome if someone reduces their hospital admission. But that's equated with dying from a heart attack, and I think most people would not equate the two as equally important. So when you use combined endpoints, there is a risk of exaggerating the benefit because you're making different outcomes equal in importance.
Now, Dr. Dubroff, that actually is quite relevant, I think, for some of the research that has just come out in connection with the American College of Cardiology. The New England Journal published the HOPE-3 trial. They actually published 3 different articles on it, but the one we want to talk about is the cholesterol lowering in intermediate risk persons without cardiovascular disease, and they used a combined endpoint. Can you tell us about that?
Yes, I think this is a really good example for a couple issues. First, the HOPE-3 was a randomized controlled trial where they gave a statin drug as well as a blood pressure medication to patients who were thought to be at intermediate risk for cardiovascular disease. The blood pressure part didn't really show a benefit, but the authors concluded that the cholesterol-lowering part with a statin drug called rosuvastatin did reduce cardiovascular events. And they used a combined endpoint of cardiovascular death, non-fatal stroke, or non-fatal myocardial infarction. And what they concluded was that there was a 24% reduction in those events. Well, the first comment is, this brings up a different topic, the difference between an absolute risk reduction and a relative risk reduction. 24% sounds impressive, and that's what the highlights have emphasized. But if you look at the absolute reductions, it was only about 1%. And if you look at the absolute reductions in each of those individual endpoints, for example, cardiovascular death was only reduced by 0.3%, non-fatal stroke 0.4%, and non-fatal myocardial infarction 0.5%.
Let's move on to another study that also kind of reinforces what you were talking about, and that is a study reported last weekend regarding a drug that was supposed to be a superstar in the world of cardiology. evacetrapib. This was a drug that dramatically lowered LDL cholesterol and dramatically raised good HDL cholesterol, the foundations of the cholesterol theory. This was a drug that was tested on over 12,000 people at 540 health centers around the world. It was an Eli Lilly drug. They prematurely stopped the trial because there was no benefit. What happened?
Well, this is a fascinating study, and my hope is it's going to shake up the world of cardiology and lipids a little bit. Exactly as you said, everyone expected this would be the dynamite drug that would dramatically reduce heart disease because it does everything right. It dramatically lowered the bad cholesterol, LDL, and it dramatically raised the good cholesterol, HDL. But in fact, there was no discernible difference in outcome between those who received the placebo and those who received the drug in terms of reducing cardiovascular events. To my mind, these results are not actually surprising because I think there has been a lot of evidence suggesting that lowering cholesterol does not consistently reduce the risk of heart disease. And unfortunately, I think many people and many physicians have either chosen to ignore these studies or are simply not aware of them. So from that standpoint, this study, which is called Accelerate, confirms other studies which did not show a benefit of cholesterol lowering. Now, whether or not one study is definitive in terms of debunking the cholesterol hypothesis, that's unlikely. But I think this only adds to quite a bit of evidence showing that cholesterol lowering does not consistently prevent heart disease.
So, Dr. Dubroff, what should people do about their cholesterol?
Well, to be honest, I think there's a little too much emphasis on cholesterol, and that's a bit strange to say as a lipid specialist. But I think the emphasis should be upon a healthy lifestyle, especially healthy diet. It's curious that perhaps one of the most powerful studies that I've seen in cardiology, which was the Lyon Diet Heart Study, randomized patients to a Mediterranean diet following a heart attack and reported a 70% reduction in total mortality, which is phenomenal.
Now, I assume that's 70% relative risk.
Correct. But what is interesting is in those patients who were on the Mediterranean diet, their cholesterol levels did not change at all. So my point is you can do a lot of benefit just by eating healthy and don't focus so much on the absolute cholesterol numbers. I think cholesterol numbers are helpful because they provide some insight into kind of your overall metabolic profile, but I'm not sure that targeting cholesterol is always the best way to prevent heart disease.
You're listening to Dr. Robert Dubroff. He's Associate Professor of Medicine in the Division of Cardiology at the University of New Mexico in Albuquerque, New Mexico.
After the break, we'll consider the risk calculator from the American Heart Association and the American College of Cardiology. Should every man over the age of 65 take a statin regardless of his cholesterol level or blood pressure?
We'll also find out if all diabetics should be on a statin. How do dietary changes compare to cholesterol-lowering medicine?
And we'll talk with Dr. Stephen Nissen of the Cleveland Clinic about the research he presented last weekend at the American College of Cardiology. His study was just published in the Journal of the American Medical Association.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you like the information you hear when you listen to The People's Pharmacy, you may also enjoy our book published by National Geographic. It's The People's Pharmacy Quick and Handy Home Remedies, available online at peoplespharmacy.com or at your favorite bookstore.
Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is made possible in part by Red X Industries, makers of utterly smooth creams and lotions that moisturize deeply to make dry skin feel soft and smooth. The number is 800-345-7339. The website is uttercream.com.
And if you would like to purchase a CD of this show, you can call 800-732-2334. This is show number 1031. You can also find it on our website, peoplespharmacy.com.
Today we're talking about cholesterol and your heart. Does taking a statin ensure that you will live longer? If so, how much longer? Will drugs like atorvastatin, rosuvastatin, or simvastatin extend life?
And if you wish, you could join our conversation through email. We're radio@peoplespharmacy.com. Our guest is Dr. Robert Dubroff. He's Associate Professor of Medicine in the Division of Cardiology at the University of New Mexico in Albuquerque, New Mexico. He's board certified in internal medicine and cardiology, and his specialty is lipidology.
Dr. Dubroff, what would you say to your cardiology colleagues who have believed for the last 3 or 4 decades that getting cholesterol down, total cholesterol, LDL cholesterol, was sort of the holy grail? And now, as you point out, there's some studies that are beginning to question that theory. Why do you think statins have shown some benefit in some studies? Is there some other mechanism at work that might account for it besides cholesterol?
Well, that's a very valid question, and there is quite a bit of discussion that perhaps the benefit of statins is not related to their cholesterol lowering, but to other effects, what we sometimes call pleiotropic effects. There's no question that in some of the clinical trials, statins are effective at lowering mortality and or preventing cardiovascular disease. But my view is it's pretty inconsistent. And I think there's been an overemphasis on the studies that show benefit and to some degree ignoring the studies that don't. So in terms of my colleagues, I think it's prudent for all of us to be open-minded and to look at all the studies, both the positive and the negative ones, and don't just focus on the ones that kind of support the theory. I think there still is a role for statin therapy, but I think the issue is we haven't figured out or defined which type of patient truly benefits from it the most. And as a result, what happens is there's a tendency to treat patients who may not really benefit from it, and you're exposing those patients to potential risks.
Well, in fact, the American College of Cardiology and the American Heart Association have come out with their risk calculator, which suggests that anyone with diabetes should absolutely be prescribed a statin, and any physician who doesn't would not be practicing good medicine. And if you look at the risk calculator, just about every man over the age of 65 should also be on a statin. What would you say to the people who came up with the risk calculator and the guidelines that are now affecting literally tens of millions of patients worldwide?
Well, this leads into a study which I recently published in the American Journal of Medicine, where I questioned this whole approach of basing statin therapy based upon a calculation of cardiovascular risk. And the problem is the evidence really doesn't support that model. It makes a lot of sense intuitively that if you're at high risk, you're probably the person who will benefit most from statin therapy. But by carefully looking at the studies, especially in high-risk populations, there is no consistent benefit that I could identify. In addition, there are 2 very important studies related to this topic. Essentially, if you use those guidelines, you want to try to prevent a heart attack. So some physicians in Wisconsin did a study several years ago where they looked at a couple hundred patients who came in with a heart attack and then went back and calculated their risk for heart disease to see if they would have been candidates for statin therapy. And what they found is, unfortunately, only 25% of those patients who came in with heart attacks would have been deemed statin candidates. So in other words, the guideline or the risk calculator in this instance seemed to fail to identify 75% of these patients who went on to have heart attacks. The converse has to do with something called the MESA study. In the MESA study, they assessed risk in a broad population of patients, and they did something called coronary calcium scores on these patients. And what they found is that many of the patients who would have been recommended to take statin therapy based upon the risk model, in fact, 50% of them approximately, had 0 calcium scores, meaning they had extremely low risk of future heart attacks. So in this circumstance, it's saying that we might potentially be treating a lot of patients who don't need to be treated with statin drugs.
Not only is that expensive, there's also the risk of side effects.
Absolutely.
Dr. Robert Dubroff, thank you so much for talking with us on the People's Pharmacy today.
You're very welcome.
You've been listening to Dr. Robert Dubroff, Associate Professor of Medicine in the Division of Cardiology at the University of New Mexico in Albuquerque. He's a lipidologist and board certified in internal medicine and cardiology.
And now we turn to Dr. Stephen Nissen. He is chairman of the Robert and Suzanne Tomsich Department of Cardiovascular Medicine at the Cleveland Clinic. He's the co-author with Mark Gilinoff of Heart 411, the only guide to heart health you'll ever need. Dr. Nissen is the lead author on the GAUSS-3 study just published in the Journal of the American Medical Association. You'll find a link to it from peoplespharmacy.com.
Welcome to the People's Pharmacy, Dr. Steve Nissen. It's so nice to have you back, and thank you for taking the time to join us today.
And it's always good to talk to you.
Boy, there was a lot of excitement last weekend in Chicago at the meetings at the American College of Cardiology. Your study, the JAMA study from GAUSS-3, raised a lot of excitement. Can you tell us a little bit about the study and what you found?
Well, we set out to try to understand better the problem of statin intolerance due to muscle-related adverse effects or side effects. There's been a lot of controversy about this topic because in the randomized studies where people got a placebo or a statin, very, very few patients would have muscle-related problems that cause them to stop the drug. But in clinical practice, people describe 5 to 10% of patients not being able to tolerate statins. So what we did is we found 500 people around the world. They had very high cholesterol levels. Their bad cholesterol, their LDL, was 212 milligrams per deciliter. That's just in the stratosphere. And we assigned them to get atorvastatin, formerly known as Lipitor, 20 milligrams, or placebo for 10 weeks. Then they crossed over, and those that got placebo got atorvastatin, and those that got atorvastatin got placebo. And during those 20 weeks, we asked them to describe whether they had intolerable muscle symptoms. And it turns out that about 43% of patients had intolerable symptoms while taking atorvastatin. Now, keep in mind, these are people that had had a long history of complaining about severe muscle-related side effects from statins. So these weren't, general population. But 26.5% of the patients had symptoms on placebo, but not on atorvastatin. And so both sides of the argument got some support here in the sense that it is more than half of the time a muscle-related intolerance is a psychosomatic illness. But a solid 40% of patients have something that's reproducible when you challenge them with a statin again.
Now, Dr. Nissen, the way you set the study up means that neither the patients nor the people conducting the study, yourself and your colleagues, actually knew during the study who was on which treatment, right?
Very, very good point. It was so-called double-blind study. Neither the physicians nor the patients knew who was getting statin and who was getting placebo. So it was really one of the first objective tests to try to understand the nature of this problem.
Well, you know what I find so fascinating about your study is there are a lot of doctors out there, a lot of your colleagues, cardiologists, internists, family practice physicians who say basically, it's always in the patient's head. They're just getting older. There really are no musculoskeletal problems. In fact, Dr. Ben Goldacre from the UK wrote an article not too long ago in which he said there are no muscle side effects because the randomized controlled trials show no muscle side effects. And yet you and a lot of your colleagues would say, but we see patients who come into the office all the time complaining that they can no longer do some of the activities they used to do. They can no longer exercise. The study does seem to suggest that a certain proportion of those people really are having statin side effects.
Yes, and the randomized trials, there's a flaw there. And the flaw is that many of them had what's known as a run-in period, where everybody got a statin for usually 4 weeks. And if you didn't tolerate the statin, you didn't get into the randomized controlled trial. And so that's not a really fair test of the true incidence of the disorder. We wanted to be more objective, and so that's why we designed the study the way we did.
Well, Dr. Nissen, it seems to me that your GAUSS-3 study has now confirmed that there are indeed some people who really just can't take statins because it makes their lives much too miserable. They aren't able to move around if they're taking a statin drug. Is there a lesson?
Yeah, I think the lesson is listen to patients. And we have to do very good science here, but there's wisdom in patience. I mean, I think you get people calling into your show all the time that describe things, and we need as physicians to be better listeners. We did find how in the study, interestingly enough, there is an alternative, and we randomized patients who had confirmed statin intolerance to either ezetimibe, formerly known as Zetia, or one of the new injectable PCSK9 inhibitors. These are the very expensive injectable cholesterol-lowering drugs approved last year. Those that got the PCSK9 inhibitor, known as evolocumab, had more than a 50% reduction in their levels of the bad cholesterol, LDL. And the interesting question was, would they have the same muscle side effects? And it turns out that only 1 out of 145 of those patients stopped the injectable drug due to muscle-related side effects. These are people that had confirmed muscle side effects on a statin.
But some of them did, in fact, suffer from muscle side effects on...
But they were generally pretty minor, and my guess is that they were more of the psychosomatic type of side effects, because if the side effects are bad enough, people will stop their study drug, and almost nobody stopped study drug in this study. So we got their LDL, their bad cholesterol, from around 220 down to 104, which is a safe level. Now, it's an expensive drug, and it's not for everybody, but if you have heart disease and you really have a high cholesterol level, we did find that there is a potential alternative, albeit one at a very high cost.
Well, it's interesting because we're now seeing advertisements for the 2 drugs that have been approved by the FDA. I think one of them, the one that you studied, evolocumab, known as Repatha, is that pronounced correctly, or Repatha? Repatha. And the other one is Praluent. Now, we don't have any clinical trial data yet that demonstrates a reduced risk of heart attack, strokes, and improved mortality stats. But there was a study that was announced, the data, and I think you might have even been involved with it, called Accelerate, evacetrapib. And this was a drug that was like going to be the superstar of all superstar drugs in this field. It lowered LDL cholesterol just phenomenally well, and it raised good HDL cholesterol 130%. What happened?
Well, in fact, I did share that study. The GAUSS-3 and Accelerate were presented back-to-back at the American College of Cardiology meeting. Accelerate presented by my colleague, Dr. Steve Nichols. This drug is known as a CETP inhibitor, and without getting into the weeds, it's a drug that changes cholesterol metabolism in a way that was believed to be favorable. It lowered the bad cholesterol, LDL, about 37%. That's as much as, 10 to 20 milligrams of atorvastatin, so it's a good amount. And it raised HDL, the good cholesterol, 130%. And it had absolutely no effect on cardiovascular morbidity and mortality. No reduction in death, no reduction in stroke, no reduction in heart attack. This study serves as a warning that we need to have large, carefully conducted outcome trials before we assume that a drug that alters cholesterol will in fact improve outcomes. Now, I'm optimistic that the PCSK9 inhibitors will in fact reduce the things that we really care about, the adverse outcomes that patients suffer. And the reason I'm more confident of the PCSK9 inhibitors is that they work by a mechanism that's quite analogous to what statins do. They upregulate the receptors in the liver that pull cholesterol out of the bloodstream. That mechanism, we think we understand it very well. Having said that, the old adage, and I hate to quote Ronald Reagan, but trust but verify. We need to verify that, in fact, the PCSK9 inhibitors are providing the benefits that we hope that they'll provide. Those studies will be completed in about a year.
Well, we'll be watching for that for sure. Dr. Nissen, you mentioned that those new drugs, the PCSK9 inhibitors, are probably not for everyone. So I'm wondering if you have advice for our listeners, especially the ones who don't have heart disease. How can they keep from getting heart disease?
Well, lifestyle is still the cornerstone. And, we know that, a good diet, that controlling obesity, keeping your body weight down, having a normal body mass index, and exercise are enormously beneficial. Exercise, if you look at the effect of exercise on mortality from heart disease, it's as good or better than any drug in our armamentarium. And obesity is really driving a lot of diabetes, and of course diabetes also is a driver of heart disease. So the best way to prevent heart disease is to prevent it from starting in the first place, and that means eating right, keeping your weight down, exercising if possible on a daily basis, and most people will do very well. But some people have a genetic form of high cholesterol known as familial hyperlipidemia. And they can have LDL, bad cholesterol levels, very high, above 190. And those people are generally going to need a drug. Now, what we've hopefully done here is we've better understood that there are, in fact, some of those people who cannot take a statin. We've provided a rational alternative. And if that alternative, if the PCSK9 inhibitors show benefits on reducing death, stroke, and heart attack, then I think we have a very important pathway to help people who would not otherwise be able to be helped.
Dr. Steve Nissen, thank you so much for talking with us on the People's Pharmacy today. You've been listening to Dr. Stephen Nissen, chairman of the Robert and Suzanne Tomsich Department of Cardiovascular Medicine at the Cleveland Clinic.
When we come back, we'll find out about a mysterious food allergy that strikes many hours after you've eaten beef, pork, lamb, or other meat.
What's the connection between tick bites and allergic reactions to bacon or barbecue?
We'll get the latest info on alpha-gal allergy, its diagnosis, and treatment.
You're listening to The People's Pharmacy with Joe and Terry Graydon. If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is made possible in part by Red X Industries, makers of utterly smooth creams and lotions, helping dry, cracked skin feel utterly soft and smooth. 800-345-7339. Online at uttercream.com.
If you would like to purchase a CD of this show, you can call 800-732-2334. Today's show is 1031. Or visit the website peoplespharmacy.com.
Some people are allergic to eggs. Others break out in hives if they eat a shrimp. But what about a delayed reaction to hot dogs, bacon, or barbecue?
To help us better understand the mysteries of alpha-gal allergy, we turn to Dr. Maya Girath. She's head of the Allergy and Immunology Clinic at the Thurston Arthritis Research Center at the University of North Carolina in Chapel Hill. She's board certified in internal medicine and allergy and immunology and has a special interest in food allergies, particularly in the diagnosis and treatment of alpha-gal meat allergy.
Welcome to the People's Pharmacy, Dr. Maya Girath.
Thank you so much.
Dr. Girath, can you please tell us a little bit about alpha-gal allergy? We've been talking with Dr. Thomas Platts Mills at University of Virginia for years, and in the beginning it seemed like this was really rare and kind of peculiar. And now we keep hearing about more and more cases of this very strange allergy. What's going on?
Absolutely. Well, I think our understanding of this condition is growing. And as is the case with many medical conditions, when more and more people become aware of it, it seems like the incidence of something is going up. So I think, while we thought it was rare before, I think that was largely because nobody knew about it and nobody knew how to diagnose it or when to diagnose it. But as we've been learning more about it, we are discovering that it's actually not quite as rare as we thought.
Maybe you could tell us what it is and how it shows up.
Sure. So this is an unusual allergy, and the reason I say that is because it doesn't seem to follow the rules of a traditional food allergy. It's an allergy to a sugar, where most food allergies are to a protein. And this sugar is contained in the food products that come from mammals, so four-legged furry creatures like cows and sheep and pigs. And when you ingest this allergen, you are at risk, and if you're allergic to alpha-gal, you're at risk of having an allergic reaction to it. The reaction typically shows up about 4 to 6 hours after you've ingested the food, and it manifests just like a typical allergic reaction. So that means you could break out in hives and develop severe itching. You can have abdominal distress with cramping, nausea, and vomiting. You could develop difficulty breathing and wheezing, and in the worst case, because of a sudden fall in your blood pressure, you could lose consciousness.
Well, when you say a typical allergic reaction, everything you describe fits except for the GI part of it. Because when people are allergic to something like a bee sting, for example, they often break out in hives. They may have trouble breathing, but they don't necessarily develop abdominal pain, nausea, and vomiting. And so I'm suspecting that some people initially, they come into the doctor's office or the emergency department complaining of, terrible digestive tract problems, and maybe they get diagnosed with food poisoning, and it's really an allergy, and nobody realizes that.
Well, that's true. So what you said is certainly correct. With something like a bee sting and or with an allergic reaction, say to cat dander, you don't develop gastrointestinal symptoms. But with food allergies otherwise, so for example, peanut allergy or shellfish allergy, gastrointestinal symptoms can be very common. But what you say is absolutely correct. Many people are not diagnosed correctly, not just because not everybody knows about this allergy, but because I think one of the earliest signs of this allergy is gastrointestinal distress, and it may be present without any of the other symptoms. So no hives, no itching, nothing else. And so I think for years, many people write off this allergy as having a quote-unquote sensitive stomach. So when I diagnose people with this allergy, which is often after they've had a more severe reaction with hives or anaphylaxis, once they cut meat out of their diet, they suddenly realize that all these years, for the last 5-10 years, when they thought they just had a sensitive stomach, it was that they were having low-level alpha-gal allergic reactions.
Dr. Girath, you described that the reaction actually doesn't start right away, and that's something that we usually think of with food allergies. We usually think, you take one bite of peanut butter, and if you're allergic to peanuts, bam, you're in trouble already.
Exactly, and that's yet another way in which I was saying before, alpha-gal refuses to obey the rules. So, yes, the reaction sets in typically 4 to 6 hours later rather than immediately like you described. And it's also the reason why many people will wake up in the middle of the night with these symptoms, because they've eaten their beef or pork-containing meal, at 7 p.m. They go to sleep, and at midnight or 1 o'clock in the morning, they're awake with this allergic reaction. So, yeah, that's another way. And the third way in which it doesn't follow the rules is that the reaction is not 100% reproducible. With traditional food allergy, we say that if you're allergic to, say, peanuts, then each and every time you're exposed to peanuts, you're going to have an allergic reaction. But with alpha-gal, you could eat a steak today and have no reaction, and then eat one tomorrow and have a severe allergic reaction. And that's one of the most frustrating things about this. And I think another thing that obscures its diagnosis.
How can we enhance communication between patients and physicians, especially emergency department physicians, who may not have had the kind of experience that you and your colleagues have at University of North Carolina or University of Virginia?
That's a good question. And so partly it's the onus is on us and other physicians who are seeing this condition and, researchers such as ourselves that are conducting research in this area to disseminate this information, which we certainly try to do by publishing papers in the literature and by presenting at national and local meetings to sort of spread the word. The other thing is I think the Internet has been very helpful in this. I've had a lot of patients that have come in saying, I did a Google search on tick bite and allergy, and this is what I think I know what I have. And I've had many patients tell me that they've actually printed stuff off the Internet and taken it to their physician or to the emergency department because they figured out what's been going on.
How does the tick bite fit into this? Because we're talking about a food allergy, not a tick allergy, right?
Right. So that's the big question here is how do you develop this allergy? We do think that there is a fairly strong link to a tick or chigger or potentially some other bite. And we're not sure exactly how that triggers this allergy. We don't know if it's the direct cause of it or if it's something in the tick saliva that's, serving as an enhancer or an unmasker of this allergy. That's part of the research that we are conducting is to try to figure out exactly how it fits in. But there's, it does seem that there's a correlation between tick bites and the development of this allergy.
How is the allergy treated? What's the best treatment?
So, unfortunately, as is the case with all food allergies right now, the only treatment is to avoid exposure to the antigen. So what I advise my patients to do is to strictly avoid all mammalian meat. So that would be beef, pork, lamb, venison, rabbit, any of those kinds of food. And then on top of avoiding the obvious sources, they do have to be careful about hidden sources because, as many of my patients have made me aware, turkey sausage is often encased in pork intestine. A lot of beef broth is the base for a lot of vegetable soups. Some people use beef tallow as an additive to frying oil when they prepare French fries to enhance its flavor. There can be fatback or bacon in vegetables. So there are a lot of places where they have to ask questions and be careful. The other thing that I found is that most of my patients do tolerate dairy products. And so even though that is a product that comes from a cow, most patients are able to tolerate it. So that's one piece of good news. And then the other thing that I do tell my patients is that we have found that the level of this antibody in your blood does seem to wane over time. And I do have 3 patients who have outgrown the allergy or who have cleared the allergy and are back to eating meat. So I think there is a cause to be optimistic that this is not forever.
Dr. Jarath, can you tell us a little bit about the research you're doing and what your hopes are for the future?
Absolutely. So we are doing, essentially I would categorize it as 2 types of research. First, we learn about alpha-gal from our patients. I mean, as is the case with many medical discoveries, you make them by listening to what patients tell you. And when patients come in repeatedly telling you something that doesn't fit with the paradigm that you currently understand, you have to question what your understanding is. So I'm learning about the characteristics of this allergy and through listening to my patients and following their clinical course and trying to make correlations between something about the patient and what predicts whether they're going to have a severe reaction or a mild reaction, because we have some patients that are super sensitive and react to even the smallest exposure. And then others who, might by mistake eat a bite of beef and have no problems at all. So we're trying to understand what it is that leads to these different manifestations of this disease. We're also trying here at the Thurston Arthritis Research Center to learn about what role the tick plays in the development of this allergy and what immunologic markers or what genetic markers, so what things in people's blood can be predictors, again, of who will clear the allergy or who will have a more severe manifestation of the allergy. And my hope for the future is actually that by studying this condition and understanding it better, not only do I hope to help the couple of 100 to 300 patients that I personally take care of, or the thousands of people who have this condition in the country, and probably many, many more who've been undiagnosed. But most importantly, what I'm hoping this will do is allow us to get a better fundamental understanding of food allergy in general. I think the fact that alpha-gal doesn't follow the rules tells us either that it's the one unique exception, or that maybe our entire paradigm is slightly faulty. Or if not faulty, maybe our paradigm is limited and it works in certain settings, but that actually there's a much bigger view of food allergy to be had, into which alpha-gal as well as traditional food allergy would fit if we would just take a step back and look at it through a bit broader lens.
That's really a pretty exciting idea. So might there be other food allergies that don't follow the rules, as you say?
Absolutely, that we don't know about yet. And, maybe that could be an explanation for a lot of the conditions right now that people suffer from that they don't have a diagnosis for.
Dr. Maya Jarath, thank you so much for talking with us on the People's Pharmacy today.
Thank you so much for having me.
You've been listening to Dr. Maya Jarath. Dr. Jarath is head of the UNC Allergy and Immunology Clinic at the Thurston Arthritis Research Center. That's at the University of North Carolina, Chapel Hill. She has a specialized clinical interest in the diagnosis and treatment of alpha-gal meat allergy, and you'll find a link to her webpage with more information at peoplespharmacy.com.
And we invite you to join the conversation by email. It's radio@peoplespharmacy.com.
Jonathan, welcome to the People's Pharmacy. Please tell us your story.
Hi. This is my story about the alpha-gal allergy. About 5 years ago, I had a couple of pretty severe reactions that, I had no idea what was causing them. I had 3 one summer, and just full-body hives, itching from head to toe, my scalp sort of on fire, really, really bad gastrointestinal issues, just really like the sort of the worst indigestion you could ever possibly have. And then the third reaction, I had those things, plus I started having some trouble swallowing and a little bit of breathing. Thinking about going to the emergency room, but I sort of had an idea that it was some sort of allergic reaction. I had no idea what to. And so I had taken some antihistamines and avoided the emergency room. And in retrospect, I probably would have gone, knowing now what I know.
Yeah, it sounds pretty scary.
It was, absolutely. And just the fact that I had no idea what was going on, sort of it was baffling. And I thought, what could this possibly be?
So how did you figure out, or how did your doctor discover that it was an alpha-gal allergy?
Sure. So I made an appointment with my general practitioner and described what was happening, and they referred me to an allergist, to Dr. Maya Jarath, who's so I got lucky because when I told her my story, she had a hunch that was it immediately. She had several patients. She's one of the sort of leading experts on this in the area, and at that time, I don't think there was a specific blood test. There were sort of proxy tests, just different mammalian dander tests, and she confirmed that this is what she thought it was, and she told me about it, and, I had never heard of it before. So it was a total surprise, not knowing what to expect, and then the answer was a complete surprise.
So how are you doing now?
I'm doing great. I kind of joke that I'm healthier for it, that I can't eat beef or pork. I have trouble with dairy too. Not quite as severe reactions, but severe enough to limit or avoid dairy. I tell people that I'm healthier, that that I think it's easy to avoid. But just recently, I was with my 2-year-old son, not paying attention. I got something off of a food bar. Wasn't eating mindfully, and just ended up eating something that I thought was like a chicken masala. It turned out to be some beef, and had a pretty bad reaction later, and which is scary because luckily my wife had come home, but when I was thinking about it and thinking what would I do if I really had a severe reaction, need to go to the hospital, needed to an intervention like an EpiPen while I was watching my son. That was
right.
So. But for the most part, I avoid it. Occasionally I'll, accidentally or just mindlessly eat too much dairy and have a slight reaction, which is some itching and a little bit of indigestion. But other than that, I'm able to avoid it.
Jonathan, thank you so much for sharing your story with us today.
You're welcome. I just hope more people know about this allergy.
Well, Joe, we have an email from Jen who wants to kind of emphasize that you really do have to be careful. She says, this last year we visited my brother-in-law who had cooked eggs in bacon grease that morning. He wiped out the pan and cooked a cheese sandwich for me at lunch. I had a reaction just from the leftover bacon grease in a pan that had been wiped out. She says she and her husband now use 2 sets of pans, one that they use to cook meat for him, and one that they use for her never gets any meat in it.
Yeah, you have to be especially careful if you're that sensitive. We also got an email from Pauline, and Pauline says she started getting hives. She went to the emergency room. They gave her all kinds of medications. They didn't figure out what it was. Eventually, she did get diagnosed, but she had a reaction when she went on a kind of camp out, to marshmallows. I mean, who would ever imagine that marshmallows could trigger an alpha-gal allergic reaction?
Marshmallows are not the only candy that have gelatin in them, and gelatin is a problem for people with alpha-gal allergy. So you have to be really careful. It's not just meat. It's lots of other things as well, including some medications. So watch out.
Watch out because, the gelatin capsule on medications could trigger the reaction for people who are super sensitive. Well, that is all the time we have. Thank you so much for listening to The People's Pharmacy. We want to thank Dr. Steve Nissen for joining us live and sharing his experience at the American College of Cardiology meetings in Chicago last weekend. And we want to thank Dr. Robert Dubroff of the University of New Mexico, and we want to thank Dr. Maya Jareth of the Thurston Arthritis Center at the University of North Carolina at Chapel Hill.
Lynn Siegel produced today's show. Al Wodarski is the engineer. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
To order today's show, you can call 800-732-2334. Today's show is number 1031. Again, that number, 800-732-2334, online at peoplespharmacy.com. You might want to share it with your doctor or share it with a friend. And when you go to the site, you'll find out information on prescription drugs, herbs, and home remedies.
And a little bit more about alpha-gal, too. You can even subscribe to the free podcast of our show or subscribe to our email newsletter. It's free, and it's all there at peoplespharmacy.com.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Be sure to join us next week. We'll be exploring apitherapy with a beekeeper and healer.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.